I'm a staff scientist, soon to be a research assistant professor at the University of Washington, and I collaborate with all of our hospitals that participate in the surgical care and outcomes assessment program. Yeah. And we meet monthly, so I'm going to talk a little bit about some of the research we've done as a collaborative group across many hospital systems and many clinics. I'll talk about our certain research group, how we meet, and then 2 of the studies we're doing, and one of which hopefully you're passing around surveys that you will participate in yourselves as surgeons in the room. So this is a really interesting way that we have partnered in the space of quality improvement and research. Neil leads the group across the state looking at signals for quality improvement for safety and care. And then I come in with our group and we answer research questions based off of these signals. So you can see, a lot of times there's a clinical question, and we can take that clinical question and develop a research question. We gather data to answer that research question. We report our findings, as we've seen a lot of interesting publications today about adverse events, and then we can implement those findings, or we can take what we've learned and improve care. And so that goes back into the quality improvement space. And then we can look for pre and post in the quality improvement in practice. And then there's this opportunity for interventional research studies. So once we see these signals, we look at some early data, we get some preliminary findings, we can actually take this preliminary data and develop protocols by which we can actually study an intervention. So how do we do this? We have a network of clinics and hospitals that participate in this group called CERTAIN. And we've done a few projects in both the research and quality improvement space. And so today, actually, you're participating in some of, hopefully, the stakeholder input by helping us understand research priorities in the space of spine infection, and in particular, the use of intrawound antibiotics. And we take this information, we create studies that generate evidence, and then we disseminate them into practice through various quality improvement programs. So who is this research collaborative group? We call ourselves CRIS, very acronym friendly. It's spine scope surgeons, key opinion leaders, so people outside of our network in the state participate. Some people you probably know in the spine community, and then health services researchers. I'm actually a health economics and outcomes researcher by training, but also collaborate with other health services and epidemiologists and biostatisticians in this space. We meet monthly over the phone where we prioritize our research projects. We go through findings. We look at signal in the spine scope data and discuss future projects. And then we hopefully have enough signal and enough data that we propose some multi-center prospective studies. And we have 2 that were funded by NIAMS. So the first one is the first of what we've done from this group. NIAMS funded an R21 for 2 years. We're going to go into a 3rd year no-cost extension in the space of spine fusion. And what we're looking at is we're using the PROMIS measures. I don't know how many people are familiar with PROMIS and the outcomes measurement system, but we're actually using it in a baseline to understand, can we predict patients that most likely might improve from a spine fusion surgery? So really looking at people's biopsychosocial risk factors ahead of surgery and understanding their pain catastrophizing, social support, let's see what else we have, sleep, and various pain measures as evidenced by the PROMIS system, that the measures that are available to us. Then we measure their response to surgery based on a 15% change in the ODI. And then we're also doing a side study looking at their baseline MRIs and seeing if we can come up with some prediction characteristics as well to look at their outcome. So we have sites participating. ProLiance, UW Medicine, Evergreen, and Confluence are all actively enrolling patients. We hit 100 about 2 weeks ago. We're at 107 patients. We're hoping to get 150 by June, and we'll then follow patients. Their early time point, we're looking at 30 to 90 days at their ODI, and then we're going to follow some of those patients out to a year. And then today I'm hoping some of you will be able to fill out our spine infection survey. This was a second NIAMS funded study, another R21 for 2 years, and it was really to focus on a planning grant for how we might study infection. in the spine surgery community. And we know that this is a popular thing that surgeons use. So what happened early, this was a great study where we looked at the effect of intrawound antibiotic use on surgical site infection among hospitals participating in spine SCOAP. I'll show you some early data that came from that, and there was a paper published out of our collaborative with this study. And then second, we took that information and we developed the survey that you'll see here today to get an idea of how this is used, and if we were to plan a trial, what that would look like in practice, knowing that some people are using this and it would be difficult to change that usage pattern for people who are using it, and for those who aren't, how do we introduce something? And this is a really unique opportunity to do randomized trials in surgery, which is difficult to do. So planning it ahead of time ensures that we will get more buy-in from the people who are actually participating in the study. And so our third aim is to actually design the feasibility of doing an RCT in this space. And I have some early results, but I don't want to bias anybody taking the survey today. So you'll have to look for us at some future meetings where we will present some of this data. So as it's in progress right now, we're going to do one more survey round at the Lumbar Spine Research Society meeting in April. And then we'll work on deciding if there is actual feasibility in designing a randomized controlled trial to study the use of vancomycin or intrawound antibiotics in surgical site infection. So it was interesting, our early study showed that there was no significant association found between the use of IWA and those hospitals that do and do not use it and the rates of surgical site infection. So you can see in the lower end where intrawound antibiotic use is on the x-axis here and surgical site infection rates are on the y-axis. And you can see, we have, it's all over in terms of variation. You have some low users with low rates, you have some low users with high rates of infection, and then on the other end, again, you see a little less of high infection rate for higher users, but this cluster here shows that there's definitely variation. And this was a propensity matched adjustment, so we were able to adjust for all the risk factors that people would want to adjust for in patients who might be more prone to surgical site infection. And when we did all of our adjustment, both at the patient level, and then we did a separate analysis at the hospital level, we found no difference. So I hope you'll participate in our survey today. You can do it on paper as I handed out, or you can use that QR code and go online and do it. You can do it on your phone or a website or a computer. And that's all I have. So thank you for letting me come and do a little research talk for those of you. I'll be around today if you want to ask any more questions about our research collaborative or any other ideas you might have for research prioritization in the space of spine surgery. Thank you.